Greg Swarbrick, thank you very much for coming on a Saturday afternoon to share our conference with Physio First. Greg leads the development and use of quality data across Bupa's UK various provider and insurance businesses, Head of Healthcare Outcomes at Bupa. His current work includes developing a quality framework for musculoskeletal conditions in all care settings.
Okay, well, good afternoon, everyone. Thank you very much for inviting me here today, Pam, Physio First, and everyone. It's a pleasure to be here. So I'm Greg Swarbrick. I'm Head of Healthcare Outcomes at Bupa UK. I recognised last week that having been in the job for 5 years that my acronym was HOHO, which was... there we go. It's just one of those things. We were talking about acronyms of different people, and I thought I didn't want to be an acronym until I realised what I was. So in terms of being Head of Healthcare Outcomes at Bupa UK, what that means is that I work with all of our different businesses, both provider and insurer businesses. So that includes our care homes, our dental practices, our health clinics, our hospital, Cromwell Hospital, as well as the insurance business, to really understand what are the right, most appropriate measures of quality. How do we collect those? How do we record the data? And how do we really use that to improve patient care, which is what it's all about. So very wide range. I'm a generalist. I'm not a specialist. And really, I'm going to sort of talk a little bit about why I'm here today. So 3 years ago, I was asked by our insurance business, so really the commercial people, I'm not commercial, to advise them on what the right measures of quality should be when renewing the outpatient MSK Physio network. And I'll talk about that through the course of this journey. And the reason that they wanted my advice was that a frustration, I'm sure, shared by many, is that you have one very, very simple measure of quality, so to speak, which is the number of treatment sessions, which really isn't very satisfactory. And we wanted to move on beyond that because it's what our patients want. Most of all, we understand that the number of sessions causes frustrations for the practitioners as well. As an insurer, we also want to make sure that we're getting value for money, that we're getting the right outcomes. So that was definitely a challenge. So in terms of the what do I mean by outcomes? This is the Bupa view. What I've been sort of developing over the last few years in terms of what we mean by outcomes. And as I just said, number of sessions. In this trivial pursuit model, you've got a blue segment which represents efficiency. So in this context, and this refers to all of the contexts of healthcare that Bupa is involved in, you've got efficiency here, number of sessions, but in hospital it might be number of nights stay and so on. But that's very, very crude as a measure of quality. So what we have are different measures of quality, the outcome measures, which collectively, and that's the really important point, you can't say what is quality just looking at one particular measure. It's just not enough. You can't say that 5-night stay is right for a patient in hospital. For some, it might be 3. It might be right to have 6 for other patients. And sometimes these different segments, they're conflicting with each other. So I had a problem with the boiler on Wednesday. We had 2 people come along. The first one was very rude, and he messed it up even more. The second one, really nice guy, and he fixed all of the problems, and I was very happy. But from a customer's point of view, I was thinking, well, we're paying the same amount to both of them, and that's not good. So how can we move on to really represent the quality, the full rounded quality of what we're commissioning here as an insurer and what we're delivering here as a provider? So you've got patient satisfaction, another positive, health impact, the most challenging of all, the PROMs, because trying to get follow-on PROMs responses is a massive challenge. I've seen that within patients as it's been implemented with the private healthcare information network. We're talking rates of 5–10%. It's not good. And that's because the patients don't always understand it. They're not always guided towards that by the clinicians as something that just is part of the clinical pathway. But it needs to be. They need to appreciate how important it is to have this data. So you want health impact, you want patient satisfaction, you want efficiency as a collective measures of outcome, and particularly in inpatient contexts and for day surgery as well, you want to collect the things that may happen that might be outside your control, like the clinical incidents, mortality and so on, the complaints which you're going to get whether you like it or not. That's the flip side of patient satisfaction, and safety, the sorts of measures that should be prevented. And for these slides, very happy to share these afterwards. I realise there's quite a lot of information on the screen. So on the next slide, like I said, this is quite a bit of information. I've talked about what are outcomes, now about why quality and outcomes are important. And I've divided it into three columns. Because it's good for patients, it really helps them understand what they're hoping to get in terms of getting better, what that looks like in terms of improvement for pain, function, quality of life. It's good for clinicians to understand how well they're doing and areas to improve on. And from a commissioner's point of view, and this is for Bupa, this is a slide I've been working on for the last year or so, as a provider as well as an insurer, it's really good from an insurer's commissioner's point of view of making sure that you're getting the right quality that you're hoping to deliver for your customers. So obviously more detail here on the slide itself, but and there are overlapping interests here as well. But this is good for all of us to have quality measures. We want it. Now the tricky bit is how to get all that information, and that's the challenge. But I hope, I really want to impress on probably an audience that you're aware of this already. How do we make sure that this is collected and used to improve healthcare, which is what we want? So I'll come back to my little journey here. So I was asked to identify what would be good quality measures for private healthcare. And I thought, well, what I can't be doing is telling people these are the measures and that's that. That would be wrong. So started having a number of conversations with different organisations. So Pam and Paul from Physio First, we ended up having conversations with a whole range of providers, and I had a sense we're repeating the same conversations. We're all really interested in this, but we're all like little islands speaking slightly different languages. It became clear that some organisations are not collecting any quality data whatsoever. Other organisations are collecting some standardised measures, but there was a complete fragmentation in terms of what's being used, and that doesn't enable standardisation and comparison. So we got together a working group of these organisations, and it's always been very open, always happy to have more people at the table, more views, and having providers and insurers and professional bodies sitting in the same room, listening to each other, hearing what was good for one organisation or frustrations with another organisation in terms of quality. We very, very quickly actually got to a really positive vibe, for want of a better word. We were listening to each other and being able to understand each other's points of view. And quite quickly, we found points of common interest, because obviously quality is important to all of us. So even if new members came to that group and it was sometimes a bit fluid, very quickly there was a sense of this works for all of us. And we are not in any way saying that this is a perfect model, but it's good enough for us right now to start off with. So we had this working group, we listened to each other's points of view, and what we ended up with was a set of recommended measures and also a sequence to get us from complete fragmentation in private healthcare in terms of the measurement of quality to standardization. Now, obviously, that doesn't happen in one step. It will take what we've worked out as being 3 steps to get there. We're not at this stage mandating particular measures because we just don't know what everyone else is using. But the important starting point is that everyone is collecting measures of quality. That's the bottom line. And this type of thing is certainly influencing Bupa from the commissioning perspective. We want to be able to work with organisations that are demonstrating an interest and a commitment to the recording of quality. That's the first step. Once we know what everyone's using and what the pros and cons of different measures are, we will be in a better position to work out collectively, providers and insurers and professional bodies, what would be sensible and would work for all in terms of standardized measures. So we're not there yet, but we need to be collecting this data. And we're really impressed with Physio First QAP and QA C schemes in terms that they fit the model very well. And this model there are things that are incomplete about it. It would be really nice to know about return to work, but we couldn't get that agreed by all of the working groups, so we've just left it out for the time being, but it would be nice to have that later on. So it's a starting point. And as I said, in terms of direction of travel, we are incorporating this into our commissioning increasingly. I guess the important point from a commissioner's point of view also is that we don't want to be commissioning blindly. We do want to trust more and more and more. And in fact, where we've been moving to in the last 6 months or so is setting up working with clinical groups who, once they show that they have got all the right measures in place in their area, they've got the right processes, we're devolving more and more responsibility to them. And that seems to be working very well. It's about 10 or 12 groups we've approved so far, but we definitely see that as the direction of travel, that we as a commissioner shouldn't be holding so much, that we should be devolving more and more trust, more and more responsibility, authority. You know the patients best, but we can't just trust blindly or pay a check blindly. We need to have, I think it was Ronald Reagan was saying something along the lines of, you need to trust and verify at the same time. And it's an interesting balance, but we do need data, because otherwise we would be completely in the dark, and we don't want to be there. So as we start to have quality data, I mean, I look after the Bupa clinics, which is we have physiotherapy, GP services, various musculoskeletal dermatology. Now that we're starting to collect data in exactly these formats that I've been talking about, it's fantastic, because you can start answering questions around, what's the right length of stay for a particular initial, condition that the patient has. And we can see that different patients, different types of condition need different things. And that's the right level of detail we want to be getting into. But again, it's data that gets us there. And obviously that's very important for managing the patient's expectations, and also for the clinicians as well. So my last slide is, I guess, just a bit of a caveat, but also hopefully a positive one as well. Where we're moving to in this whole thing about data is that data is great, but people are more important. And I say that from the point of view of seeing lots of data recently, for example, looking at our GPs and finding one person who's prescribing to 49% of his patients, another person to 13%. Thinking, why is there the difference? And it's easy to rush to some sorts of conclusions, and that is precisely the wrong thing to do. The way I see outcomes is that outcomes and the data is a starting point to ask questions. Because as I've asked questions about the prescribing, this GP is working in a very particular environment where the customers are extremely demanding and expect to get medication so that they can be at work at 9 o'clock every morning. So actually the data can be really, really supportive to be able to push back and say, to this particular organisation, do you know what you're doing to your staff? In another context, where we have a triage phone call service, we have, incredibly high numbers of phone calls when actually one is what you're supposed to be having. So 22 phone calls, what's happening in terms of speaking with the same patient again and again, and they're not necessarily getting better. In fact, in mental health, dozens and dozens of sessions without any evidence that it's being effective at all. So we do need to look at the data, to use that data as a starting point to ask questions, not to rush to judgment. And with that, there's a better understanding of what's right and what's appropriate, and sometimes that there are certainly interventions which are not appropriate, or it's important to have some processes in place to say we need to stop here and check that things are working, and then to move on. So in terms of supporting staff, we need to be able to talk about outcomes, to say why we're collecting them, what they are, what we're doing with the data, also what we're not doing with the data. So I guess as an end point, I'm really keen that the whole point of outcomes is to support our staff, support all providers to be able to deliver the best quality care possible, to be able to help our customers get the best care possible for them. We need to do it carefully. We need to move step by step, learn as we go through this process. But it's exactly the right thing. It's what our customers are asking for from us. Thank you.